good wake-up call for like this first exam, because it's going to be nothing like the exams we have like in pharmacy. Because like in pharmacy, it's like mostly like the exam format is basically just like all multiple choice and like select all that apply, all those fun stuff. Sometimes it's like one word answers, like we have to fill in
I
blank.
think it is just Dr. Johnson who prefers taking essay type questions,
Right.
but then I'm sure like Dr. Kevin is person. She's more into presenting stuff, discussing, sharing your thoughts. Yeah. So possibly this may be one of
maybe hopefully, yeah.
But yes, Dr. Johnson. So he's I don't know why I didn't him ask that question the other day, but then he's never keen on taking open book exams. Even last year, it was Dr. Lee who was interested in taking the open book exam. Dr. Johnson never wanted it to be an open book. But now I understand, why he's doing that.
Yeah.
But better than a take-home exam, I'm sure, like, because otherwise we spend days on,
Right. Take those exams like that would, because then it's expected to have a lot of information part of it, right?
Right.
You spend so much time and energy on
And then how much ever you right, you'll be like, there's something always.
There's always something else that you can have.
Right.
Tends to get stretched.
Right, and even and with these exams, in-class exams, at least you have this, liberty to write what you know at that point in time, and then just go leave the hall.
Don't need to worry about particularly referencing anything.
Right, exactly.
You don't need any like super fancy diagram. just like
You can skip
this circle is definitely what I meant.
Hello.
Good morning.
Morning.
How's everyone doing?
Good.
Hi, Young.
Hello.
How are you?
Good.
Good. Matt, what year are you now?
P3.
P3.
Yeah, P3.
Okay. Sorry I didn't recognize.
No.
Make
it's
the
fine.
connection. Who are you researching with?
Dr. O'Donnell.
Dr. O'Donnell. Okay, great. Awesome. How is everyone today?
Good.
Good. I'm better. I just have to wear this on campus until tomorrow. Through tomorrow. So I think the recommendation is 10 days after symptoms, so tomorrow will be the last day. Yeah. Last time I've had COVID twice, and the first time I had a headache. This time I was knocked out for like 4 days. It's just like I can't catch a break this year.
Yeah.
Actually, I should know by now. Every year, beginning of the school year, I get some kind of illness. I think it's just stress related because I have my 2 daughters
Yes.
getting ready for school. I'm getting ready for school. It's just everything starts at once, and it's like this whirlwind until we get in. Summer's pretty laid back, so by the time we get more into that craziness, I think it ramps up so quickly that I just get so stressed and everything goes crazy. And we have an exchange student from Italy this year living with us. So that adds. So it's like having 3 daughters. So it's fun though. She's great, but it's just a lot. This will reach. I got the longest one I could get. Thanks. Yeah, thank you. Okay, I don't know how this classroom works. To project up there.
So, Dr. Kevin, should we just sign into one of our accounts?
Yes, I think so.
Sends the presentation or something.
Yeah, that would be great. Yeah, can you do that, Vivek? This classroom's totally different. Oh, it's up there. I see. Maybe. They took all our classrooms away and Bear.
Right.
So
Yeah,
different.
Bear, Melon, everywhere. For the med school. Oh, I forgot that we have Zoom too, right?
Right.
Yep.
Go ahead. You can sign in. I guess, right? How do I zoom that person in?
You can still access your audio.
Yeah, that's true.
From
Yeah. Hi, Sana. Good. Better. Getting better. Oh, Muslim. Yeah. Thank you. wondering where the heck we are. So if I put this Zoom meeting on here, you can find it on your Canvas site, correct?
Yes.
But provided Chetan has activated the notification system, like if he has not checked on the notification,
Oh,
he
okay.
won't receive.
You won't see it.
Mm.
Okay, so what if I send him a?
Yeah.
What if I put in an announcement? Would you find it there? Because it'll send him an email, right? I'll just put Zoom. It is the 7th, right?
Yes.
Okay, you should get this now, right? Does it email it to you? Yes.
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 And also let him know.
Okay, thank you. Thank you, thank you. And then, how will he see your presentation?
We can share, like we can share our screens on Zoom, etc.
So, but you all have to be on Zoom, right? No? Oh, you can just, oh yeah, you can just share it on here.
Recording in progress.
Okay. Has Dr. Johnson been recording these? Yes. He has? Okay. Right, okay. That should work. Okay.
Hello.
Hi, Muslim. How are you?
Good.
So we'll wait till Shaitan signs in. Give him a
Like
minute
he's
or two.
joining.
Yeah, that's okay. Give him a minute. Okay, there it is. Hi, Chaitan, can you hear us?
Yes, I can hear you.
Okay, great. Well, welcome. So today, the plan is just to go through your presentations, just like 5 minutes or so, 5 to 10 minutes on your paper. And we're going to start with the G protein coupled receptors. But before we get into that, was there any questions about what we went over on Tuesday with the signaling pathways and the kinase receptors versus the nuclear receptors, cytokine receptors, anything? Any questions? No? Yeah? Okay. All right. So, G protein coupled receptor, I think Afsana?
Yeah.
Yes? You were one, so do you want to go first?
Yeah. So, do I email it to anyone?
I'll open my Outlook.
Okay, so I'll email it.
Yes. So we're gonna email our presentation to Vivek, because he was kind enough to help me log in here. And then we'll share on the screen so you can see Chetan, okay?
All right.
Okay. Chetan, where are you actually?
I'm in India,
Oh, what part of India?
Mumbai.
Mumbai. One of my best friends, his name is Chetan as well. Oh. Okay, so can you email to me?
Oh, yeah, sure.
One of my best friends, his name is Chetan. So, anyway, I guess it's a pretty normal name, common name in India.
Yeah, it's a very common name.
Yeah. What's your last name, Chetan?
It's Timburi.
Timburi. He's Gandhi. Okay, if you email to me. Some of you, I think, already did, actually, but. Okay, we're just getting the presentations emailed, and then we'll get started. And then I'll put all the papers up today. I got some of them later last night. I just didn't get to it. But I'll have all the papers up just so you can all see what everyone's found. And come on, email. I don't know. Sometimes I wish we could just go back to pen and paper and.
I think.
Here we go. Okay. Okay,
This
you can
one.
see this, correct, Chetan? Okay, good.
Hello, Chetan. I hope you can hear me as well.
Yeah, I aren't you.
Okay. So, good morning and welcome, everyone. So, the target of today's assignment was to find a paper, preferably a primary research paper, that details a drug mechanism of action which focuses on G protein. For me, it's G protein. So, the paper I chose, it does not directly describe the mechanism of action, but it's one of the landmark papers that established the use of this specific drug that I'm going to discuss today. So it is losartan potassium. I think all of us have heard of it either through our academic background or someone in our family must have taken this at any point of time. My father is on this drug since 2010, so yeah. So losartan potassium is angiotensin receptor blocker. It's first of its kind, and it was directly compared with enalapril maleate, which is an ACE inhibitor. So the reason this paper was very important because enalapril was very popular drug to control blood pressure, but this is one of the landmark trials that convinced American Heart Association to prescribe losartan or ARVs as a first-line drug for hypertensive patient.
Maybe. Oh, there.
Oh, okay. So the goal of this study was it's a 8-week double-blind placebo-controlled trial. So one group was receiving enalapril, and another group was receiving losartan potassium. The thing was, the group that was receiving enalapril, the dosage does not change, did not change over the time. It was 20 milligram. But for losartan, they did a dose response study. So in this study, they took around 500.
There you go.
This is the study design. As you can see, that running day was the day they checked in. Their first dose was taken, and then the blood level was observed at first dose at 2 weeks, at 6 weeks. So the goal of this study was two things. One, how effectively it reduces the blood pressure in a hypertensive patient, and second, how long does the effect remains. So they test the peak blood level of these drugs and the trough blood level, meaning when the drug was supposed to be at its lowest point in the blood. And then they compare the efficacy of it. So this is the major findings. So as you can see, this is the supine diastolic blood pressure of enalapril and losartan. You can see a lot of graphs. So one of them is the placebo group. One is 25 milligram of losartan, another one is 100 milligram losartan, and another one is 20 milligram of enalapril. They just wanted to show you the effect of these drugs over time. So the very first one was the first dose. This was 2 weeks, and this was 6 weeks after. And the top line is the baseline, meaning what was their blood pressure when they just came in, and then they administered the drug and just observed the reduction in the diastolic blood pressure. So both of the drug was effective in almost equally effective in reducing the blood pressure, but losartan has more lasting effect in this patient compared to enalapril. So that was one of the major findings.
Wait, can you go back to that a second? I'm sorry. So it looks like it's 6 weeks though, and the enalapril, is that how you say that?
Yeah, enalapril. Yes.
Which is the X, right?
Yeah, that's the X.
Looks like it's more effective, right? Is that correct? Am I reading that correctly?
More effective, but how they presented the data was at 6 weeks level, the blood level of losartan was higher than the enalapril.
Is this okay?
Longer lasting effect. So once daily dosing of losartan would be more effective as compared to enalapril. That's what their conclusion was, and this is change in diastolic blood pressure. Yes, enalapril is reducing blood pressure more as compared to higher doses of losartan.
Okay.
But losartan is supposed to be
Just
working
staying around longer. Okay.
So once daily dosing would be perfect. And this is also another portion. So in previous slide, I presented the supine diastolic blood pressure, and this is the change in aldosterone. And as we'll see later in the mechanism of action, aldosterone is another reason why, another way losartan reduces blood pressure, other than other than acting as an antagonist. So as you can see, the aldosterone level was also reduced. So placebo is the top one. As you can see, from baseline to week 6, the placebo group, the aldosterone level actually did not reduce it. But from baseline, the 25 milligram, 100 milligram, and 20 milligram of enalapril, all of them kind of has a reduction from the baseline from aldosterone level. And as aldosterone is reduced, there is less retention of sodium ions, and it's released more through kidney, and the blood volume is lower, and as a result the blood pressure is also lower. So that's another findings of this study.
Can you just wait right there? Just a general comment for when you're when you're writing your own papers. You see how they changed the symbols in that graph?
Yeah, enalapril was crossed
Yeah.
in the previous
Don't
one.
do that. Keep them the same throughout your paper, okay? I don't know what the advantage of that is.
Yeah,
Okay.
so enalapril would be that one in that case, and the lowest of the lowering of aldosterone was highest in 100 milligram of placebo.
Yeah.
It gets very confusing.
Right.
I mean, it's black and white, and then.
So part of this is for your assignment, but also to see, to kind of critique these journal articles as well. And I think that's a major flaw because it's very confusing. Just keep them the same throughout the paper. It's much better for the reader.
So now that I have described the major findings, not described, just briefly overviewed the major findings, let's actually jump into the signal cascade. So it was not actually based on one paper, it was work of multiple papers and years of work for multiple labs. So this is the basic signal cascade of how angiotensin, when binds to AT1 receptor, what happens. So before going into that, I will just briefly go into that renin-angiotensin aldosterone system. I wish I put a slide for that, but I think it's just an overview. So when blood pressure drops, the prorenin from our kidney turns into renin, which converts angiotensinogen into angiotensin 1, which is an which is a peptide containing 8 amino acid, and then those angiotensin 1 is 10 amino acid, and from that ACE converts into angiotensin 2, which then binds to AT1 receptor, which is G protein coupled receptor, and then the signal cascade starts. Upon binding to the receptor, as we already learned that G protein is always in this trimeric form, alpha, beta, gamma. So this signal cascade starts. Beta and gamma kind of dissociates, and alpha dissociates with GTP. So BIP turns into these two separate entity. One is diacetyl glycerol.
Diacylglycerol.
Diacetyl, yes.
Yeah,
And then another one is IP3. So diacylglycerol went on and start the PKCM MAC ARC pathway, and then it goes into nuclear signaling and proliferation. And the IP3, it converts into, it goes into ATP, CAMP, phosphoryl kinase, and then just all those, they kind of reduce all those and directly showed that it affects, it releases calcium ions, which binds to L-channel, L-gated calcium receptor, and then vasoconstriction happens. So this mechanism is there for maintaining our homeostasis. Whenever our blood pressure drops, our body will automatically get it back to the normal level. What happens into hypertensive patient is this pathway gets overactive. So renin secretes more than necessary, or autonomous, so without any signal. So this pathway gets very activated. More calcium is released in the blood, and we know that calcium will cause vasoconstriction. So as a result, blood pressure is increased. So ideally, not ideally, previously the drug that was prescribed was ACE inhibitor, as we discussed enalapril. We should inhibit the ACE enzyme, angiotensin converting enzyme, so that angiotensin 2 is not produced. But that had multiple side effects like dry cough and other stuff. So they were searching for another option. All the scientists are searching for better option. But so that case, ARB comes in. It directly losartan competitively binds with AT1 receptor and displays angiotensin 2. As a result, this whole cascade is.
1 second.
Yeah.
Right back there. So you know that Dr. Johnson went through the G protein coupling signaling.
Yeah.
So what did he talk about the different types of G alpha? Yes. So which G alpha signaling is this?
S G
G
I
GS
GIGS.
Which one is it?
Alpha.
It's not GI. It's not GS.
GQ.
GQ. Yeah. GI and GS both work through adenylate cyclase, right? GS stimulates adenylate cyclase. GI inhibits adenylate cyclase, right?
and this one.
And cyclic AMP is the second messenger. GQ works through phospholipase C. And then the second messengers are diacylglycerol and inositol triphosphate. IP3 is a ligand for those calcium channels on the ER, right? And we know the endoplasmic reticulum sequesters intracellular calcium to control the levels. So when IP3 binds, then that's where the calcium comes from. Yeah. Okay.
And there was another paper that came into my search, which I did not actually look into that much other than that.
That's okay.
To be honest, which was kind of getting into this idea that losartan, since it also can block this pathway MAC or nuclear signaling, it can be used in cancer as well. So that's like the newest direction that this drug is going on.
So part of the I don't want to say issue, I'm trying to think of the right word. Part of the concern of blocking high at the receptor like that is you do block all that intracellular signaling.
Yes.
So now, at least some of my research and others, we're looking at to block further down in the pathways so that you're more specific to that pathway, and then you're not disrupting all that information inside the cell.
Like if possible, blocking just this portion.
Or even down by MEC. MEC is where we're targeting, And some people are even trying to target the MAP kinase itself, so ERK1 and ERK2. Turns out that's a really difficult target, the actual MAP kinase. It's really hard to inhibit those for some reason. So a lot of people go one upstream to the MEC. Yeah.
Ma'am.
Yes.
Then again, we don't know like which path it will take. Like the step
Right.
one or
No, you're right. And then a lot of times what happens is you block one, the other one compensates. Yes.
So.
Yep. So actually, just another plug for my research, we're now trying to dual inhibition of two pathways at the same time.
Then it would not be any benefit of like instead of blocking the receptor.
Right, but well, at least in cancer, the thing is that these pathways, some of these pathways are upregulated and others are not as upregulated. So if you can target the upregulated pathways and kind of leave the other ones alone, they can compensate somewhat in the normal cells. So it's tricky. It's a balancing act.
In cancer, we can just like try that.
Yes.
That you are
yes,
doing. Like.
Yes.
But in this condition, like in hypertensive
Yes,
drug,
right.
it doesn't matter. Like
No.
you are blocking the receptor or
That's right.
the signaling pathway.
That's right. That's right. Yes.
So it was GQ. I did not look into my presentation.
Yeah, there it is. GQ.
Yeah, there it is. So what I was saying that how losartan potassium reduces blood pressure is it replaces angiotensin 2 from its receptor, and it competitively binds with this GQ coupled protein receptor and specifically AT1 receptors. And what happens is upon binding, it kind of inhibits the rest of the process. So losartan blocks the conversion of PIP2 to inositol triphosphate, and if inositol triphosphate is not formed, it will not increase the intracellular calcium channel level, and it will not bind to the L-type calcium channel. So this whole process is blocked upon binding of losartan. So that's the way losartan potassium is mainly responsible for vasodilation, and it is also responsible for aldosterone secretion, which results in less sodium retention in the blood. So more sodium is released into with kidney with urine, and blood volume reduces. So in two ways, losartan potassium is reducing blood pressure. And another thing that I mentioned earlier, that losartan potassium works once daily dosing. The reason behind it is the active metabolite of losartan is also very potent antihypertensive. So that's another function that they found. So losartan is metabolized into E3174. They haven't come up with the name of it yet. So that's the whole process, like renin, angiotensin converting engine, and losartan like blocks this angiotensin 2 binding to that receptor. And not only losartan, when it's metabolizing to EXP3174, it acts also as a potent antihypertensive. It has more longer half-life. So that is why once daily dosing of losartan was very effective, and it kind of very quickly replaces the previous first-line antihypertensive. Now it has better version of it, like losartan is replaced by olmesartan, telmisartan, and they're bringing out more and more specific ARVs, but the main mechanism of action is kind of this. They are just trying to minimize the side effect or potentiate the effect, all of them. So that was my take on G-protein complexity. I
Very
hope it was
good.
clear.
Excellent.
Thank you.
Thank you, Alsana.
It's very difficult.
I know, it's strange. Who else had G protein? Couple of stuff? Was it?
I have the next ion channel.
Who was it?
Chetan.
Chaitan, you ready to talk about your work? Okay. Did you email it to me? Or you could probably just share, actually. Hold on, let me just give you ability to share. I'll make you a co-host so you can share your screen, okay? Hold on one second.
Open preparation.
Okay, stop this share. Okay, now you can share your screen. Ooh, okay, this is cool. I'll turn your volume. Hold on, let me turn the volume up if I can. How do I do that? Oh, volume.
Okay. So the study that I found was a comparative study between norepinephrine and phenylephrine, and its use in disability. Although the study has not spoken on how the drug is actually working here, and I had some conflicting views also on this. So I thought maybe we can discuss this.
Sure.
Yeah. So first is so I'll be talking about GPCRs, and the content of the slides are what are GPCRs, what are the ligands that are binding to it, how is the ligand interacting onto the GPCR receptor, and then potential uses of phenylephrine. So some endogenous ligands that are binding to GPCRs are adrenaline, noradrenaline, dopamine, serotonin, and some exogenous ligands would be phenylephrine, ranitidine, metanoprost, atenolol, salbutamol, and olanzapine. Okay. So this is how the signal transduction occurs. So I think we covered most of this in the previous class. So the GPCR receptor is a transmembrane receptor where in the intracellular side we have alpha, beta, and gamma subunits. Depending on the ligand and the receptor interaction, either the alpha subunit pathways would be stimulated or the beta gamma subunit pathways would be stimulated. Now, in case of phenylephrine, so we see that the GQ and the G12 pathways are stimulated. Now, so I think so. It was mentioned in the previous lecture also that there's a crosstalk is happening between these pathways. So this particular diagram elaborates what we are looking here, and it's quite perplexing because inhibition of one particular pathway might not result into the inhibition of another pathway as well. So a homeostasis should be maintained, and I think the crux of this particular topic was to see that. So this is a brief overview of how phenylephrine works. So the adrenergic system is divided into alpha 1, alpha 2, beta 1, and beta 2 receptors, of which phenylephrine works on alpha 1 and alpha 2 receptors since it's a non-selective agonist. Now it works by two mechanisms. Either it's a direct mechanism or an indirect mechanism. In case of an direct mechanism, it works on the GQ11 subtype receptor, and in case of indirect mechanism, it actually depletes or rather it facilitates the release of noradrenaline from the presynaptic vesicle into the synaptic cleft, and thereby it facilitates the effect. Now,
Just Chetan, 1 second. Go back to that previous slide. Do you know how it facilitates that release of like epinephrine or adrenaline from the presynaptic neuron?
So there's a transporter, a norepinephrine transporter here, which is highlighted here. So via that it enters the presynaptic vesicles, and from there it sort of releases uh, the adrenaline from the vesicle into the presynaptic cleft.
So do you know what's in? So you see the P for epinephrine, and then you have it pointing to the vesicle. Does it displace the? How does that? Do you know how that gets released from there?
So it doesn't displaces it, but it changes the membrane potential and sort of this vesicle. Hold on, I'll just. So this vesicle kind of fuses onto the presynaptic neuron, and then it's released. So I'm not sure about the entire signaling pathway, but the vesicle fuses here, and then adrenaline is released.
So probably what happens. I'm trying to think here. So probably what happens presynaptically once it gets in there is it probably displaces it a bit from the. I'm trying to think here because I know directly if it binds to a presynaptic adrenergic receptor, what it's going to do then is increase the amount of calcium in the presynaptic terminal. Calcium is a signal for the vesicles to fuse. It's the first signal for the vesicles to fuse to the terminal. So that's why the epinephrine would be, or adrenaline, would be released from those vesicles. I'm just trying to understand here. I'm not really sure what. I wonder if the same thing happens once it gets into the cell. What's happening through the norepinephrine transporter? Because this is I've never seen this mechanism of pseudoephedrine actually, so I'm just trying to understand it. Does anyone have any idea what might be happening here?
Pseudoephedrine basically also releases the stores.
Yes, that's what I mean. Like
maybe this picture is related to the stores because it's not showing that it's coming from the presynaptic terminal into the synaptic cleft.
Right.
It's showing that it's doing the exchange between the P and norepinephrine is going out.
Yeah, it's somehow reversing the transporter. It looks like.
Yeah, because normally the picture which shows that there is binding of the vesicle to the presynaptic membrane and its fusion, and then it's getting out in the synaptic cleft. But here it's a bit different maybe, and pseudoephedrine has an effect of on the stores of catecholamines.
That's what I'm thinking. I'm thinking pseudoephedrine here gets taken up into those vesicles and displaces the norepinephrine from the vesicles there.
Yeah.
And then the norepinephrine is transported. The transporter then works in reverse, kind of like amphetamines. You know, amphetamines, what they do for the dopamine transporter is they are taken up by the dopamine transporter, displace the dopamine in those vesicles. They get into the vesicles and kind of kick out the dopamine. And then the dopamine transporter kicks out the dopamine, so it kind of works in reverse. And this looks like this is happening here, which I had no idea that's how one of the mechanisms of pseudoephedrine. So that's interesting.
So is it also blocking the reuptake of
norepinephrine? Right, yeah, because it's also blocking the reuptake of norepinephrine. So depleting the stores, I think, is the right way to say that, right? Because normally are you following us, Chetan? Yeah, so normally the transporter, right, would reuptake the norepinephrine into the synaptic terminal, right? But in this case, since the pseudoephedrine's there, it's competing with the norepinephrine. It's getting into the presynaptic terminal, displacing it from those vesicles, I believe. That's what this looks like is happening. And then once it's displaced from the vesicles, because it's so concentrated in the terminals, the neuron wants to get rid of it. So the neuron kicks it out through the transporter, the norepinephrine transporter. So the transporter works in reverse. So you kind of have a double effect here, right? You're depleting the stores, you're blocking the transporter.
Yep.
And that's how amphetamines work as well. That's why they're so addictive, because they spike up the levels of dopamine so quickly and so dramatically. Does that make sense, Chaitan?
Yeah, it does. Yeah, I think it also depends on the route of entry because in case of phenylephrine, if we use it as a nasal spray in contrast to IV infusion or to an oral tablet. So
yes, it's definitely going to depend on the route of administration. That's correct. Yeah. Okay. Sorry. Thank you. I just wanted to clarify that. You can keep,
So the next slide speaks about the uses and also the concentration and also the route of administration. So it depends how we are going to use the drug, and based on that, the concentration changes. So it's being used as a nasal decongestant as a mydriatic for fundus examination and as a vasopressor. Now, this particular study was performed in 688 females. So, the objective of the study was to check non-inferiority between norepinephrine and phenylephrine um, for the treatment of hypertension. So, it's been observed that during a cesarean delivery, in case of norepinephrine administration, so there is more of hypotension and also there is more of fetal, I wouldn't say toxicity, but chances, there are more of complications in those cases. So they wanted to check the effect of norepinephrine versus phenylephrine here. So it was a randomized double-blind parallel arm trial with 688 individuals. So the inclusion and exclusion criteria are not mentioned on the slides, but the exclusion criteria was uh, uh, any pregnancy-related complication, in case of the health of the fetus, if it was not optimum, and so in those cases the females were excluded from the trial. The route of administration here was by an IV infusion, and we can see that the primary outcome was umbilical arterial pH. Since it correlates very well with both the neonate as well as the female's health, so hence this was chosen. And we could also see here in the graph that umbilical arterial blood gases, venous gas exchange. So everything was optimal. Rather, it wasn't better compared to the norepinephrine group, but it wasn't inferior also, which suggests that phenylephrine can be used in case of norepinephrine here. So they haven't performed any mechanistic study here, but what I think here it could be that instead, since they are giving these via the intrathecal route, one of the mechanisms could be that it goes and it stimulates both the alpha and the beta receptors, and because of that, the hypotensive effect is seen less in phenylephrine over adrenaline.
So the alpha receptors GQ coupled, correct? Chaitan?
Yeah.
The
Yeah, so it typically stimulates the GQ and G11 receptors, and because of that, there is an increase in blood pressure. So kind of like a dual effect. So since here we can see that adrenaline is non-selective, so it will bind both to alpha and beta receptors. But in case of pseudoephedrine, it is selective and it binds to alpha 1 via the GQ-GS mechanism. So I think which is IP3 and ISL pathway.
And I think
because of that, there is less of hypotension.
Less hypertension, right? Just like what kind of the mechanism we just saw with Afsana. Also, and I think the beta receptors are alpha S, I think. I should know this. I can't remember off the top of my head. They might be, yes, alpha S, right?
Alpha 1, beta 1, beta 2, all are S.
S, right.
Alpha 2. Alpha
right.
2 is I.
Yes, that's right. Okay. So they're using the pH of the umbilical cord blood right?
Yeah.
As a predictor of hypertension or hypotension?
Hypotension.
Okay. So this would be given to a woman during delivery, or how would that work?
So this was given just before the delivery.
Just before the delivery, okay. Okay, so if they had a hypotensive crisis during cesarean delivery, they're trying to see which would be better, norepinephrine or phenylephrine?
Yeah. So statistically speaking, both of them were non-inferior. So we
Right.
can't say that phenylephrine is better than norepinephrine.
Yeah.
But yeah, it was non-inferior.
Just so we can all understand, hypotension of the mother, or is there some distress in the baby, which is the
of the mother.
Of the mother.
They have not performed any studies on the fetus.
Yeah, right. Well, that's hard to do, right? Who's going to say yes, please experiment on my newborn baby? Yeah, it's hard enough to get pregnant women, right? Yeah. Okay. Any other questions for Chetan? Okay, good. So just thank you, Chetan. Just to recap for G protein couple signaling, right? We have the G alpha S, I, Q, and then that 12, 13, the weird one. Right? And so you should know the signaling from all of those. And, yeah, basically the signaling. You should also know when you see a structure that's a 7 transmembrane spanning structure, that's a G protein. You should know the G proteins are trimeric proteins. How they get activated. The GDP is kicked off for GTP, and then how they dissociate into their subunits.
Yes.
Okay. And actually, G proteins you're going to probably encounter the most if you're working with any kind of medication or testing medications, because they often work through these G protein coupled receptors. Okay, good. All right. So then after that we had ionotropic receptors. Yep. Ion channel. Yeah, those are also ionotropic receptors. So do you know that, right? The G proteins are known as metabotropic receptors. METABOTROPIC. Metabotropic, right? And the ion channels. Yep, sure, please. And the ion channels are. Maybe reload. The ion channels are ionotropic. 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 They're also known as, if you want to say ion channels go down. I'm sorry, those are all pinned to the top. Sorry. I have to go below this. Where are you, Muslim? There's Young. Oh, there you go. What was I just going to say?
Download it.
No, you can just do it there. Yeah, and then just say start slideshow. Oh, yeah. Good. Ionotropic receptors, if you want to say that they're ion channels, the more correct thing to say is ligand-gated ion channels, right? Because there's also voltage-gated ion channels that are not considered ionotropic receptors, okay?
Yeah.
Right?
So my topic was.
You're good.
My topic was drug affecting the ion channels or drug working via ion channels. So I chose lidocaine, and I didn't find any article related to the mechanism of action of the lidocaine because ion channels were discovered way back, and to find the primary article regarding the mechanism action of
dig up the
ion
dead.
channel is very difficult.
Yeah.
So what I did is I've given an intro about the lidocaine and ion channel, and then we'll move on to an article which has lidocaine content in it. So starting with lidocaine, what is lidocaine? As you all know, it's a local anesthetic. It's a pain reliever. It is used to basically prevent pain while doing minor surgeries. And how it does is basically it causes reversible desensitization of nerve endings in a localized area. Like for example, if you are doing stitching of the bones, so you have to basically give local anesthesia at this particular area. So you can prick the skin how much you want to, because it will not cause pain. Other than that, in dentistry, it is also used commonly for extraction of the tooth, doing root canals, and doing fillings. So it is also required because they are painful procedures, and you have to basically desensitize the nerve endings before starting the procedure.
It's a very good thing to have around the house, by the way, especially if you have children and they're crying in pain from a little scratch. If you just put a little bit of lidocaine on it, they get very happy. They're fine.
Yeah.
You don't put a lot, just a tiny little. Just a little tiny bit.
Just put it yesterday in my.
Oh, did you?
And then how they do it, how they basically reversibly desensitize the nerve endings. So they basically cause inhibition of the ion channel. Which ion channel they are targeting is basically, the name is voltage gated sodium channels. And now when I say voltage gated, these channels are completely dependent on the voltage.
Yeah.
The millivolts, they have a threshold. When they reach that threshold, they completely open, and then they basically, the other channels open, the other ion movement take place, and then again the voltage goes down to below the threshold, and these channels basically close. So they are dependent, or the opening and closing of these channels are dependent on the voltage basically. So how did you do is, I've just taken this mechanization, and I will read that the lidocaine can reduce the peak currents of sodium channels and accelerate the deactivation process to reduce the excitability of neurons. Once you don't allow the sodium to come into the cell, so basically then there will be no current change. And if there is no current change, there is no action potential, and there will be desensitization of the nerve endings. And this way it prevents or reduces the sensation of the pain. This is a picture showing normal voltage gated sodium channels. On this side, you can see the resting state of the sodium channel, and here as you can see that there is a gate.
Yes, middle.
Middle one?
Yeah.
No. Oh, you want the pointer?
Yeah.
Go up top to more. There might be. Is there a pointer there? No. Where the heck's? Oops.
So I will just use this as a
Yeah,
pointer.
just use the yeah.
And if you can see, this is the gate. This is the inactivation gate. Normally at the resting position, this inactivation gate is not functional, and this gate is basically closed because the threshold is not achieved yet. When the threshold is achieved, this gate opens up and sodium comes in and causes depolarization of the membrane, and that causes action potential, and then the sensitivity or the pain occurs in the nerve endings, through the nerve endings. But when there is lidocaine is bind over here, and it causes basically closure or function of the inactivation gate, which causes this inhibition of sodium to come in for some time duration until this lidocaine is bind to this basically ion channel. So this is the way how basically it controls the movement of sodium ion. It inhibits the sodium ion to move into the cell, and inhibition of the action potential.
So it looks like the lidocaine is working from the inside of the cells. So lidocaine, is that what that's showing?
It's transmembranous. Basically, it's between the membrane. Like that ion channel is
transmembrane.
Yeah.
But you see
this
what
is the membrane.
You see where the lidocaine is in the top right figure?
This is the lidocaine.
In panel B.
Panel B.
This is not the lidocaine.
No, right?
This is the lidocaine.
Right.
You can see this. A triangle.
Yes, the
I don't know the color.
Are you colorblind?
Yeah.
Oh.
This triangle is fixed into the gate. This maybe it's blue, maybe.
But it looks like It's red. We're telling you it's red.
No, I'm talking about this. Is this blue?
Yeah, that's blue. Blue and red. Okay.
This is red. The red is the basically the lidocaine, and the blue is the gate where it binds.
Where it binds, right? But what I'm saying is, it looks like the lidocaine is coming from the inside of the cell. Do you see what I'm saying? Up in B, look at how the membrane's oriented, right? The outside is where the sodium is.
Yeah.
The inside is, where
they have made lidocaine inside, but I don't know.
Okay.
Like, is it right or wrong?
It may be very hydrophobic and go through the hydrophobic and go through the hydrophilic. Yeah. Wait. What would it be?
It should be hydrophobic.
Hydrophobic. Yes, hydrophobic. I said that right.
Yeah.
Okay. Hydrophobic. Maybe it goes easily through the membranes.
And then
maybe
it
does
from inside. I
right.
don't know.
Okay.
Right.
I just wondered if they said anything. Yeah.
So that's the way it works, and it inhibits influx of the sodium. Then, if we see what happens after that, like if the sodium is inhibited, this is the normal action potential. You can clearly see the depolarization over here,
which is red.
And then the depolarization. This depolarization is caused of the influx of the sodium, and at the peak, this sodium is continuously coming in. But after that, what happens is the calcium and other ions like potassium comes out of the cell and causes repolarization to maintain the current of the membrane. So after that, repolarization takes place, and then again the current goes below the threshold.
Do you know why it goes below the threshold?
Because of sodium potassium pump.
No, the sodium potassium pump brings it back to resting membrane potential, right? It helps restore that. But why doesn't it just stop at the resting membrane potential? Why does it dip below the resting membrane potential?
Maybe there are leaky channels which causes movement of the potassium outside.
There are some leaky channels. Yep. What else?
Isn't that
I mentioned this in HPP. Maybe you can remember.
Is it the potassium channels are slower to
close? They're bulkier and they're slower to close. That's right.
So that's the normal action potential. But you can see over here, when you give lidocaine, this action potential is completely disrupted. So you don't have depolarization, you don't have repolarization, you don't have any sensitivity of the nerve endings, and you don't have pain.
Yeah.
So this is the way lidocaine works. Coming towards the article. I've chosen this article because it can also give us one more information regarding working of lidocaine with epinephrine. Epinephrine can produce the potentiating effect on the lidocaine. So how does this happen, and what's the goal of this article is basically they are checking the lidocaine concentration in oral tissues and in the serum to check that how much epinephrine is containing the lidocaine to a particular area.
Oh, interesting.
So, and they are also looking at that is adding epinephrine to the lidocaine is deleterious to people who are suffering from hypertension. Like for example, a patient comes in and you have to do a minor surgery on it, and the patient is suffering from hypertension. Can this addition of epinephrine to the lidocaine can cause deleterious effects to that person or not? They are also checking that. So for that, first I will just give you a bit of intro. The lidocaine is the local anesthesia, and epinephrine is the vasoconstrictor. Its vasoconstricting ability is through alpha-1. They bind to alpha-1 receptor and causes vasoconstriction of the vessels. What happens in this potentiating effect is basically when you add a very small amount of epinephrine with the lidocaine basically remains in the same local area. For example, you are stitching a wound and you want the lidocaine effect to remain in that particular area for a longer duration of time. What you will give, you will add small amount of epinephrine in that lidocaine and then inject it. So what this epinephrine will do, epinephrine is not local anesthesia. It will only vasoconstrict that vessels around that area, and then the local anesthesia, which is lidocaine, it will remain in that area for longer duration of time. It gives benefit that if you use lidocaine alone, it will be of short duration because it will definitely move into the systemic circulation. But if you give with epinephrine will vasoconstrict the surroundings, and then local anesthesia will remain in that area for longer duration. So what they are looking is what are the concentration of lidocaine after injecting at a particular area. And they are also looking that is it affecting the mean arterial pressure or not.
Right.
So the study design was they took 96 white male rabbits. They divided into two groups. One group was given lidocaine with epinephrine, and epinephrine was only put 1 to 80,000 parts. Like 1 part of epinephrine and 80,000 part of lidocaine. So the concentrations was very low. And then the other group was very free of epinephrine, and it was only lidocaine. So E0 is basically the lidocaine which doesn't have any epinephrine, and E plus is the lidocaine which has 1 to 80,000 parts of epinephrine. So what we see is first they give general anesthesia because they have to inject lidocaine to the rabbits. So they gave an general anesthesia, sevoflurane 5% for induction, and then for maintenance they did tracheostomy and give sevoflurane 3% sevoflurane for the maintenance. Now there is a question that why they didn't do the normal unconsciousness, because they have to inject in the mouth. They can not directly do that.
Yeah.
So basically they are using gas sevoflurane for induction, and then they did tracheostomy for maintenance. And they also give cannula to femoral artery to check the arterial pressure. So then after that, they injected lidocaine in half of the group with epinephrine, and without epinephrine in half of the group on the molar teeth, near the molar teeth in the maxillary bone. Now what they did afterwards, they took out the oral mucosa, the bone, and they also took the serum out of every rabbit, and they checked concentration of the lidocaine. What they found was that with epinephrine, like epinephrine containing lidocaine containing epinephrine was showing that there was very low amount of lidocaine in the serum, and high if you can see over here, after 10 minutes in the serum, the lidocaine was significantly more in comparison to the group which contains epinephrine. So this means that epinephrine was restricting lidocaine to that particular area, not allowing the lidocaine to go into the bloodstream or systemic circulation. And they also checked the lidocaine concentration in the jawbone and the oral mucosa. They saw that epinephrine basically increased the lidocaine concentration in the jawbone and the oral mucosa where it was injected, and where it should stay for longer duration of time. And the last thing, they also checked the mean arterial pressure, and the effect of epinephrine was no effect of epinephrine was seen on the mean arterial pressure. That means that if you are adding a very little amount of epinephrine, which is 1 to 80,000 or 1 to 1 lakh part, it doesn't affect hypertension or it doesn't changes any arterial pressure. So you can use lidocaine with epinephrine in any patient you want. It won't affect the heart. It doesn't have any very great
That's
effects.
great.
And then what the conclusion was, epinephrine increases lidocaine concentration locally, and this increased duration action was not disturbing the mean arterial pressure.
That's really cool. Do you know if they use that today? And
yeah.
They do?
1 to 1 lakh part of epinephrine.
Are you a dentist?
Yep.
That's what you've done that?
Oh, I've given local anesthesia daily a lot of.
Right. Right, yeah. All right, thank you. Good job, Muslim. So that was nice because it showed a combination of effects, right? The epinephrine's working on those G protein coupled receptors, and the lidocaine's working on the, in this case, voltage gated sodium channels, right?
Yeah.
Yes.
It has
which
also,
is not really, I wouldn't consider that necessarily an ionotropic receptor then, because like I said, ligand gated channels are ionotropic. That's, I separate them in, I think it's more correct to separate them voltage gated versus ligand gated, right?
Oh.
You know what I'm saying? Yeah, because those are normally voltage gated, they're not ligand gated. They're not technically ionotropic receptors, but no, it's fine. Yeah, that works with what we were talking about though. Okay.
Sorry, ma'am, I just didn't realize that.
no, it works. It works fine. Okay. Are you following along, Chick-Con? Any questions?
How to measure the
Liquid
All good,
chromatography.
alright.
RC?
Liquid chromatography.
Is it possible? Okay.
They did it. I don't know.
Okay.
These slide look short.
So this is also a
It's not
body.
short.
Oh, okay.
It's a list.
Alright,
Local
well, I'll have to
list.
find one that's an ionotropic receptor.
Yeah, so yeah,
That's
thank you
fi-
for clarifying
No,
that
that's
because yeah.
It works though.
Yes.
It's still we get the idea of how how ion channels work and everything. Yeah.
So hello everyone. So I chose amlodipine as one of the examples of actually a voltage gated channel
Blocker.
receptor
Sure.
blocker.
Yeah.
So yeah, I chose this because I know quite a lot of people using this, including both of my parents.
Ah.
So yeah, that's it. Yeah, so just a brief overview of the drug. So it is actually a dihydropyridine compound, and it is one of the third generation type of calcium channel blockers used in hypertension and angina. And what is special about this is that unlike these other drugs in the same class, it is associated with a lower incidence of reflex tachycardia. So what happens is that patients taking other types of CCDs would actually experience increased heart rate, but it's different with amlodipine. So what could be the possible reason for this is that, so I want to talk to you about the different calcium channel types. So there are actually different types. They depend on, of course, the composition of what are the subunits actually involved in those receptors, and then where they are localized in the body, and then the associated physiological responses or functions that they mediate. So I would like to focus our attention on the L-type and the N-type calcium channels. So the L-type are found mostly in the, so we have the localization, and we have to focus on the smooth muscle localization, and also the N-type, which is concentrated mainly on the neurons, the nervous system. So I actually tried to find really that, because amlodipine is also an older drug, so like the primary research articles are really old, so I tried to grasp one of the 1986 papers, but the library said it will take them 5 days.
Oh yeah, that's okay.
So I got this one. What's interesting about this is that they studied both the effects of amlodipine on both L-type and N-type in trying to explain how we get lower incidence of reflex tachycardia with amlodipine. So this experiment, they use oocytes to express the alpha and beta subunits. So to differentiate the L-type, they use the they differ in the alpha 1C, and then the N-type they use the alpha 1B.
Do you know what oocytes are?
Oocytes.
Exams.
Yeah, eggs, right? Yeah, from frogs usually. Yeah.
Yes, yes, yes.
So I just wanted to make
Okay.
sure everyone was on the same
So,
page.
yeah, they used frog eggs.
Frog egg, yeah.
And then so as Muslim mentioned, voltage-gated ion channels are opened by depolarization. So they simulated depolarization from to negative 80 from negative 80 to 10, and then so that initiated the opening of the L-type and the N-type calcium channel. And so this figure tells us that the control, so nifedipine actually so these by the way, this figure tells us the current,
Right.
the current passing through the channels. So if it is
Because it's blocked.
Did they overexpress these channels in the oocytes, or are they naturally expressed?
they
Overexpress them, right?
Yeah,
Okay.
they
Yeah.
overexpress them.
It's
So
blocked.
nifedipine
Not changed.
blocking the L-type calcium channel is depicted by the increase in the
No
higher
change.
No change
yeah,
in
no
the,
change.
right in the
Yeah.
You don't get that current.
Yeah, it didn't.
yeah, right.
So it means that
Mhm.
there are no like calcium passing through that channel, so it's blocked.
Yep.
And then for the N-type, they use the conotoxin, which is a known blocker of the N-type calcium channel. So yeah, it's similar to the effect of nifedipine. So it shows blocking of the anti-calcium channel.
But the nifedipine does not block the anti,
yeah,
right?
That's the difference also. So they compared nifedipine on L and N type. So it did not.
Right.
Yeah. So.
Just looking at this figure, why do you think it was important that they used a control for the N type, like a known inhibitor, versus not? They didn't really need to use one for the L type. I mean, they could have. But why do you think it was especially important to use the conotoxin here? Anyone?
Positive control.
To check the selectivity.
Yeah.
To check the selectivity. Also, what if they put the nifedipine in and they didn't see any effect?
But then they don't have a positive control.
Right, they don't know if the assay is actually working, right? So they have to put in that control to make sure. Yes, right. Does that make sense, Tara?
Yes.
Yeah. But since you see the blocking in the top, I mean, they could have included a positive control, but that shows you that it's the experiments work, quote unquote, working.
The system is working.
Right. Mm-hmm.
Okay, and then they also so this one focuses on the N type blocking of amlodipine, which is also dose dependent. So increasing the concentrations of amlodipine causes greater blockage of the anti-calcium channel. And so this graph here at the side just shows us the voltage and current relationship. So just shows us that it did that really also a dose response relationship, and then the voltage at which these current changes happened did not change. It just stayed on this
Right.
this area, but it's the current.
But just
changes.
less of a change.
And then for further illustrations on the comparison between nifedipine and amlodipine on L and N type, so they saw that nifedipine was more potent in blocking the L type. So this is nifedipine.
Why are you saying it's more potent? I'm
So-
just testing you here.
Yeah, so it would. So they compared IC50. We're talking about IC50. So
Yeah, and just looking at the curves, how do you know the potency has increased?
So it shifted to the left.
Right.
Yeah.
Very
so
good.
it shows us it's
Yep,
more potent.
good.
But then when we look at the N type blocking, so this is actually nifedipine, so it had no effect. Only the amlodipine.
Can you say anything about efficacy in these graphs?
Efficacy.
Do you think they have this? Can you say that nifedipine and amlodipine have the same efficacy?
So when we look at the EC50,
That's more related to potency, right? So what are we looking at when we look at efficacy?
So we can measure from the top to bottom the
Yeah.
difference between top to bottom. So the first one, the nifedipine, is almost like it reaches to the 100. That's the plateau of this side, and then another plateau will be like close to the 0,
Right.
and the amlodipine probably like a 90% will be the part.
So it's
the
not quite
product.
as effective,
Yeah,
right?
yeah.
The efficacy is lower, and the potency
10%
is low.
different
Yeah.
probably, but
Right? You all understand that difference, right? And Chaitan, you're following along. So for potency, you look at the shift of the curve left or right. Efficacy, you look at maximum effect, right? Okay, good.
And then for the mechanism of action, so we saw that amlodipine blocks both L and N type calcium channels. So this inhibits calcium entry. And then eventually, in later slides, I will show you that how it relaxes the arterial smooth muscles, thereby decreasing arterial resistance, blood pressure, and cardiac afterload. So this is actually this shows the alpha-1 subunit of the L-type calcium channel. So amlodipine binds at the side of the pore. So this is the entire thing, and then the blue one are the subunits that detects voltage differences. So at the center of the subunit is where the amlodipine binds. And then just to compare, verapamil, which is an earlier generation of calcium channel blocker, actually binds at the center. So amlodipine is more like a allosteric.
So the first author here, Bill Catterall, just a little bit of my brush with fame, I guess. He was my chair when I was a postdoc. So anyway. Very cool, I know. Almost like meeting Taylor Swift, right? Okay. Yeah, yes.
Yeah, so this is really cool. Yeah, I found this really cool. So yeah, what happens inside the smooth muscle? So normally what would happen if action potential is detected by the calcium channel, so it will open, and then calcium would complex with calmodulin to form this complex which activates the myosin light chain kinase. So what it does is that, it activates contraction by initiating the coupling of myosin and actin. So just to reverse it, if calcium channel is blocked, so this complex is not formed, and so this kinase is not activated, and then myosin and actin coupling does not happen. So relaxation of the smooth muscles results. And when we look at the N-type calcium channel, on the other hand, so as we said, it's found usually in the neurons. So this is how they try to explain the sympathetic activation that happens when calcium channels are blocked. So yeah, we talked about this earlier, the release of norepinephrine catecholamines. It involves the calcium signaling. So in this particular type, we look at the N-type calcium channel. So it mediates the fusion of the synaptic vesicles to release the catecholamines. So the paper was trying to say that if amlodipine is also blocking this type of N-type calcium channel, then probably it contributes to the lesser incidence of reflex tachycardia that we see.
That makes sense. Yeah.
Yeah, it makes sense.
Yes, yeah.
That they didn't see in nifedipine.
Yeah.
And so we said that it is used for hypertension. So just to recall that blood pressure is a function of cardiac output and peripheral resistance. So amlodipine actually, so we say it relaxes the smooth muscle, so peripheral resistance is decreased, so blood pressure is decreased. And also, in addition, it increases the blood flow and oxygen supply to the heart. That's why it's also beneficial for patients with angina pectoris.
Yeah.
So so in summary, so amlodipine inhibits voltage-gated calcium channel binding to the alpha-1 subunit, both N-type and L-type, and decreases calcium entry that leads to saline cascades, produces vasodilation, increased blood pressure, and increased blood flow to the heart.
Yeah, very good. Any questions? Excellent. Very good. Okay. So we're near the end of our time, right? 10:20 is the end. Yeah. So we got through 4. That's good. That's actually pretty good. So the remaining 3 of you Matt, Vivek, and Young, will go on Tuesday, right? And then we'll continue with new material. Any questions so far about what's going on here? Or what's going on here? I don't even know what's going on here. Any question about the material that we've covered so far? No? Good. We're all on the same page? All right. Awesome. All right. Well, then I will